Hello, sir. Sir, unmute ചെയ്യാൻ പറ്റുന്നുണ്ടോ എന്ന് നോക്കൂ.
Ajay.
Sir, audible ആണ് sir. Sir,
കേക്കാം.
Sir പിന്നെ മ്യൂട്ട് ആയി.
മ്യൂട്ട് ആയി കിടക്കുക.
Unmute ചെയ്തോ?
ഇപ്പൊ കേൾക്കാം sir.
ഇനി അടുത്ത സ്റ്റെപ്പ് പറഞ്ഞേ.
Sir, സ്ലൈഡ് ഷെയർ ചെയ്യാൻ അത് പറ്റുന്നില്ലേ?
ഷെയർ സ്ക്രീൻ ഉണ്ടല്ലോ താഴെ.
sir.
അത് ഞാൻ ആ സ്ലൈഡ് മുഴുവൻ ഇതിൽ വെച്ചിട്ടുണ്ട്.
ഓക്കെ sir.
അത് പ്രസ് ചെയ്യണോ? വേണ്ടല്ലോ.
അല്ല സാർ, സൂമിൽ തന്നെ
അത് വേണ്ട സാർ, അത് അങ്ങനെ തന്നെ ഇരുന്നോട്ടെ. ഷെയർ സ്ക്രീൻ ഞെക്കിയാൽ മതി.
ആ ഒരു ഗ്രീൻ ബട്ടൺ ഉണ്ടാവും സൂമിൽ തന്നെ, സൂം ആപ്പിൽ.
സർ, ഷെയർ ചെയ്യാൻ പറ്റുന്നില്ല.
പ്രശാന്ത്, അത് ഏതായിട്ട് ഒരു താഴത്തെ അറ്റൈനല്ലേ ഒരു കവർ ഉള്ളത്, പിന്നെ പി ഉണ്ട്, പിന്നെ സൂം ഉണ്ട്, ഒരു പെട്ടി പോലെ ഉണ്ട്. അത് ഏതാത്? ഗ്രീനാ?
സാറേ, ആ പീല് നെക്ക, പി ഉള്ളത്. പി
പ്രസ് ചെയ്യണം.
സാർ, ആദ്യം ഷെയർ സ്ക്രീൻ നെക്കിയായിരുന്നോ?
അത് ഒന്ന് നോക്കട്ടെ, ചെറിയൊരു പ്രശ്നം വന്നതില് നോക്കട്ടെ. പ്രശാന്തേ, ഒറ്റ മിനിറ്റ്. അത് അങ്ങോട്ടും കൂടെ മാറണേ. എന്തൊരു കഷ്ടായത്.
സാർ, ഒന്നുകൂടെ ആദ്യം തൊട്ട് ചെയ്ത് നോക്ക്.
ആദ്യം തൊട്ട് ചെയ്യാം, അത് നല്ലത്.
താഴെ ഷെയർ സ്ക്രീന് പ്രസ് ചെയ്യാം. അപ്പൊ കുറെ വന്നില്ലേ? സൂമില് ഏറ്റവും താഴെ ഷെയർ സ്ക്രീൻ കാണാലോ, പച്ച കളറില്.
There's a problem. അയ്യോ പ്രശാന്തേ, നീ അങ്ങ് ഓടി വരുമോ വീട്ടില? അജയ് അജയ് അജയ്,
ഹലോ സാർ.
ഒന്ന് പറഞ്ഞേ.
സാർ എവിടെയാ? സാറെ സൂമില് താഴെ ഷെയർ സ്ക്രീൻ ഞെക്കുക ആദ്യം.
അപ്പൊ ഞാൻ തിരിഞ്ഞോ? ഇപ്പൊ നിങ്ങളെല്ലാം എനിക്ക് കാണാം.
സാർ ഇപ്പൊ സൂമിലല്ലേ ഉള്ളത്? സാർ അതിന്റെ ഏറ്റവും താഴെ ഷെയർ സ്ക്രീൻ എന്ന് പറഞ്ഞ ഓപ്ഷൻ കാണാം. സെക്യൂരിറ്റി, പാർട്ടിസിപ്പൻസ്, ചാറ്റ്, ഷെയർ സ്ക്രീൻ.
അതിലോട്ട് വന്നിട്ടില്ല. ഇതില് അത് കേറിയിട്ടില്ല ഞാൻ.
അത് സാറ് സൂമിലല്ലോ ഇപ്പൊ ഇരിക്കുന്നത്.
ഞാൻ ഇതൊന്ന് വൈഡൻ ചെയ്ത് നോക്കട്ടെ. ഇപ്പൊ കിട്ടി. സ്ക്രീൻ കിട്ടി. അത് പ്രസ് ചെയ്യട്ടെ.
ഷെയർ സ്ക്രീൻ അത് പ്രസ് ചെയ്യും. അത് പ്രസ് ചെയ്യുമ്പോ സാറിന്റെ സ്ക്രീനില് കുറെ ഐക്കൺസ് വരും. അതില് പി ഉണ്ട്, പവർ പോയിന്റിന്റെ ഐക്കൺ
പി ഉണ്ട്.
അതിന്റെ മേലെ പ്രസ് ചെയ്തേ സാർ. പ്രസ് ചെയ്തോ? അതെ. യെസ് സർ, ഇപ്പൊ കാണാം. ഇനി സ്ലൈഡ് പ്ലേ ഞെക്കിയാ മതി. സ്ലൈഡ് ഷോ.
ഇന്ന് ഇതിനൊരു പ്രോബ്ലം ഉണ്ടായിരുന്നു. ഞാൻ അന്ന് പ്രശാന്തനെ കൊണ്ട് റെഡിയാക്കിച്ചിട്ട് വന്നതേ ഉള്ളൂ. അപ്പൊ എനിക്ക് സംശയം. ശരിയായി. ഒറ്റ സെക്കൻഡ് കൂടി ഞാനൊന്ന്. റൈറ്റ്, ശരി, തുടങ്ങിക്കോ അജയ്. അജയ് തുടങ്ങിക്കോ.
Okay, good evening everyone. So welcome to IAP Kozhikode PG classes. So today we are having a session on congenital hypothyroidism. The session is taken by none other than Dr. C.K. Sasidharan. Sir is actually the former head of the Department of Pediatrics in Government Medical College, Calicut. Right now, sir is working as senior consultant in pediatrics and neonatology in Baby Memorial Hospital, Calicut. So it's a privilege to hear from sir. So sir is an authority in the endocrinology as well as he is the pioneer in starting neonatology department in CMC. So over to you, sir. Sir, can you do the slide show?
Okay, let's start.
Yes, sir. Sir, slide show nekko. അല്ല സാർ, ഏറ്റവും മുകളില് സ്ലൈഡ് ഷോ എന്നുണ്ടല്ലോ. സാർ ഇപ്പൊ കാണാം. സാർ ആ സ്ലൈഡ് ഷോ നിൽക്കിയാൽ മതി ഏറ്റവും മുകളില്.
ഒരു മിനിറ്റ്. സ്ക്രീൻ സ്കെയറിംഗ് ലൈവ് സ്റ്റോപ്പ്. അത് ഏതാ? വിച്ച് വൺ? സ്ലൈഡ് ഷോ.
സാർ സ്ലൈഡ് ഷോ.
ഞാൻ പതുക്കെ തുടങ്ങട്ടെ എന്നല്ലേ?
Yes, sir.
ആണല്ലോ. I'll start.
Nihas okay അല്ലേ?
Yes, sir.
Ready അല്ലേ? Anyway, sorry for the delay and the starting trouble.
സാറിന്റെ
എന്താ
വീഡിയോ
വേണ്ടേ?
അല്ല.
നോക്കട്ടെ. You can hear me.
Yes, sir. Yes, sir. Clear answer. We can start, sir. Continue, sir.
I think I will start.
Yes, sir. Sure, sir.
Video is not so, don't worry about it. Okay, I think it is time to review our concept and the road we traveled towards the diagnosis and management of congenital hypothyroidism. Years back, it was only the clinical diagnosis of hypothyroidism, especially congenital hypothyroidism, made by as clinicians. And as students, younger faculty members, we were astonished to confirm the diagnosis by only one single investigation, that was X-ray of the knee, which does not show the epiphysis. And very rarely we could estimate serum alcohol which was elevated. At the time, we depended upon the clinical diagnosis and then confirmed by this investigation. Now the time has changed. And let us go to that. And now we know that if somebody asks a younger postgraduate student, you please mention the preventable causes of mental retardation, the first answer is congenital hyperthyroidism. Then, of course, there are so many other things which you can tell. Of course, we are preventing the mental retardation, but what about the altered skill and mental growth of these children? There has been to work out the incidence of this condition all over the world, and people are estimated to be between less than 4,000, 1:4, or sometimes where 1:3,000 per live births. In India, it is assumed to be less than 3,000. But I tell you a story. I did in the days of 1980. I had collected filter paper samples of cord blood and sent to Delhi to Dr. Kozhikode. I think he was the endocrinologist at All India Institute of Medical Sciences. And we estimated the thyroid hormone in the filter paper blood. And out of 2,000 samples, it was positive in 6 cases. So Kerala is a low thyroid, hypothyroid incident area. So just collected that information. In other places, certainly very high. Now, the commonest cause of congenital hypothyroidism in our setting is mainly because of the thyroid dysgenesis. Embryology and this thyroid development, we know that the epithelials get needed around 3 to 4 weeks prenatally, at 3 to 4 weeks of gestation. And you appreciate thyroid hormones around 12 weeks of gestation. Then after another 6 to 8 weeks, the TRH assets are detectable or at the end of first trimester. Remember, at 3 to 4 weeks, the cells getting deposited or knighted. Then another 8 weeks, the T4 and T3 and T4 secretion starts. Then releasing hormone and thyroid stimulating hormones detectable by end of first trimester. The hypothalamo-pituitary thyroid axis is certainly insufficient. So the thyroid production is less, but it comes around 18 to 20 weeks. So during the first trimester, the thyroidogenesis occurs and there is certain release of hormones into the system. The fetus is depending upon the transplacental transfer of thyroid hormones from the mother. Only the second half of the gestation, thyroid hormones increase. As a result, it is being produced from the fetal thyroid gland. We know that it is synthesized in the thyroid. You know the follicular epithelium and the colloid. There is trapping of iodine and thyroglobulin into the colloid, and then ultimately the thyroid hormone is released into circulation. And this is a beautiful graphic representation of thyroid hormone synthesis. It is along with the iodine into the system, and then it is incorporated into thyroglobulin. It is incorporated into the thyroglobulin. And then through the oxidation mechanism of iodine, this iodination occurs. Along with the iodination of thyroglobulin, there is conjugation mechanism. And through the conjugation, it is endocytosed to the cells and proteolysis occurs, and ultimately the T3 and T4 is released into circulation. So everything is happening in the thyroid cell, endothelial cells. The synthesis of thyroid hormone, and just repeating for the benefit of the listeners, uptake of iodine molecules, then oxidation of iodine molecules, coupling of iodotyrosin residues, resorption of the thyroglobulin colloid, then proteolysis of the thyroglobulin and release of thyroid hormone into the blood. Recycling of the iodine is happening on one side, and the peripheral conversion of T4 is happening to T3. The transporter hormone is occurring in the plasma, they're bound to the protein, thyroxine binding global EVG, reversible binding. You also know that only a fraction of the T4 and TS exists in free form in circulation. This is the hypothalamo-pituitary thyroid axis. Remember, the T3 and T4 exerts a negative feedback on the hypothalamus. Thereby, use of TSH is decreased. Similarly, its effect on pituitary, the release of TSH is decreased when T4 and TSH increases. Peculiarities as far as the thyroid status is concerned. There is early postnatal surge of hormones. I still remember initially when thyroid screening was introduced in our state, there were people talking about my TSH level very high, 60, 80, 100 like that, what to do? Because it was done at birth. Sometimes it was taken from the cord blood, sometimes it was taken within a day or so. In a very busy hospital, especially government hospitals, It does not happen in the ideal situation. They collect the blood and the value becomes very high. This is quite natural. It is very high. And within 60 minutes of delivery, if you take thyroid estimation of it is extremely higher. There is also the rapid fall occurs day 1 and it decreases to 10 units by the end of first week. So this day is extremely important for confirming the diagnosis. So also T4 level, it is increases to peak level by 24 to 36 hours. And there's a gradual decline by 4 to 5 weeks. It takes almost 1 month for its gradual decline. And preterm infants, they demonstrate a blunted response. I think this is a graphic representation of what I have been telling. So just concentrate on the TSH. See, this is the surge. It goes up within first few hours and gradually it comes down and reaches to 10 by about 120 hours. Something happened for T4. Initial rise and gradually down, take few days. Similarly for T3, that also comes like that. Now, reverse T3, we don't usually estimate it, that continue to play to and then it gradually dips. Now, etiology of congenital hypothyroidism. You can classify them into two. One is a permanent hypothyroidism. Second is transient hypothyroidism. When you say it is permanent hypothyroidism, you mean dysgenesis. That means something happening in the development of the thyroid. It may be aplasia or hypoplasia or ectopia. That is, ectopia means it is located in the abnormal place. Then comes thyroid hormone biosynthesis defect. The hormonal synthesis may be at fault. Then iron deficiency in certain endemic areas where totally deficient iron intake happens also leads to hypothyroidism. Then hypothalamo pituitary, this is what is called the primary hypothyroidism, which we diagnose very rarely. Now, transient hypothyroidism, on the contrary, is something related to the inhibitory immunoglobulins, binding to TSH binding inhibitory immunoglobulins. Then exposure to goitrogens by the mothers, thyroid drugs. Then prematurity produce that, and sick thyroid syndrome in sick infants. Thyroid dysgenesis is a commonest cause of congenital hypothyroidism, affecting 1 in 4,000 live births. This is usually sporadic. Females, male preponderance usually seen in them. There is specific gene identified, of course, TIT-F2, PAX8, and TSHR. Now, thyroid hormone defects. It's account for almost less than 15% of the total number of patients. So, hormonal defect is only seen in less than 15% of the patients. These are inherited autosomally. And the defect lie in the various steps in thyroid hormone formation, like organification, iodothyroxine coupling, deiodination, thyroid globulin synthesis, and secretions. Every type of formation of hormone and its release into circulation may be at fault. The commonest cause of this defect is the thyroid peroxidase activation and iodine deficiency. Pituitary hypothyroid is said to be very rare. I think I've seen only 4 children so far, and is estimated 1 in 50,000 deliveries. That means the number of patients that we must come across more than what we have registered or what we have seen. It should be more. It may be isolated, or it may be in relation to any of the pituitary abnormalities, pituitary hormonal abnormalities. There may be hypoglycemia, prophylaxis. If you diagnose congenital hypothyroidism, and if you see micros, and the patient is likely to have hypoglycemia and growth retardation, yes, you must get the so-called primary hypothyroidism, or what is called the hypothalamic pituitary hypothyroidism. Transient hypothyroidism, I told you earlier, that is the transfer of TSH binding pituitary immunoglobulins. This is from the mother. I think this is the reason why every antenatal mother nowadays undergo thyroid screening. We also know that as a mother is euthyroid, the functional status of the child, development of the child is going to be affected. You saw that especially during first half, the baby has to depend on its own thyroxine level. Only second, the transplacental transfers, and that keeps the baby's thyroid function normal. This is the reason why some of the patients with congenital hyperthyroidism, they appear normal. Only the whole assessment is for getting abnormal values. So every mother should be screened for thyroid status, and if needed, she must be supplemented with oral thyroxine for a normal development of the fetus. Now, transient hypothyroidism is effect wanes for 3 to 6 months, up to 9 months. Very rare syndrome, Wolff-Chaikoff effect. This is sick preterms when they are given povidone for disinfection. See, that can be absorbed transcutaneously and can lead to thyroid dysfunction. Intake of iodine-containing expectorants by pregnant is also found to halt. This is the status. Thyroid hormone, the functioning of the gland and the release of hormone is found to be slightly at a lower level, and also reflects the underdevelopment of the hypothalamic pituitary thyroid axis. Sick euthyroid syndrome is suppression of the pituitary's function and response to TRH with inappropriately low TSH. That means the T3 and T4 also going to be very low. I think this is worth repeating to you. All these clinical signs were only available, only clinical features made us to diagnose clinical hypothyroidism. Post-maturity, if the gestation extends more than 42 weeks of gestation. For gestation late babies or abnormally large babies. Prolonged neonatal jaundice. Nowadays, any baby coming with over first week or even extending beyond second week, we pick up so many cases of congenital hypothyroidism only on this finding alone. Then constipation. Some of them may be pale. Feeding difficulties, sucking is also very common. And any baby that comes to you, you palpate the skull and you look for a wide posterior fontanelle. It is not wide, it is very small, just like a dimple-like thing which you see in a term baby. Rough, dry skin. Hypotonic. Hypothermia. They develop frequent hypothermia and the skin get mottled, and the cry is typical post cry. And also quite interesting. Any baby with congenital heart disease, please upload hypothyroidism. Chromosome anomalies, we know that Down syndrome, large percentage of Down syndrome children will have hypothyroidism. Microcephaly, unilateral clubfoot. subluxation of hip, then midline defect like cleft palate, cornea, all this should have a suspicion of hyperthyroidism coexisting. In newborn screening, we depend upon the cord blood, the blood sample taken on 4 to 7 days or 6 weeks. We depend on T4, T3, T4, then free FT4 and TSH. I think the first line itself, the cord blood, T4, everything is all right because that surge has not set in on the cord blood. So look at the it is high. The T4 is high. TSH has come down. And 2 to 6 weeks, almost average, but T4 is still slightly high. So this value, you should have a cutoff value to take into account to suspect hypothyroidism by further investigations. Now, a positive screening test on a filter sample. This is the basic investigation. We do that. Serum T4, FT4, and TSH. If the values are normal, that diagnosing hypothyroidism is out. But if it is abnormal, don't start immediately on, the question is to start immediately on treatment, but wait for a day or so and go for thyroid scintigraphy. This is extremely essential for finding the exact cause of hypothyroid. Thyroid scintigraphy. You pick up ectopic thyroid. The question is confirmed, then need lifelong replacement therapy. Then comes normal, fine. Thyroid scintigraphy is normal. Then you can go for the thyroid binding immunoglobulin measurements, because placental occurring that can have this type of manifestations. Absent uptake, go for an ultrasound. Ultrasound being normal. No thyroid, absent thyroid. I'll come to those things subsequently. So, when you have a cutoff value 20, you proceed further by scintigraphy. Subsequently, you can go on treating the patient depending on the scintigraphy finding. Till now, scintigraphy was not mandatory. Depending upon the value of TSH alone, people started treating hypothyroidism. That practice we should revise, we should change. Now, just say some of the things. Agenesis of the thyroid. There is no thyroid tissue in the thyroid bed. See, I think nothing here. Deficient uptake. Uptake deficiency. There is not a single trace of the radioactive iodine taken up. This is hemiagenesis. See, one half, only 1%, the other half is absent. Right. Ectopic thyroid. This is double ectopic thyroid. You can see a notch here. These two. Lingual thyroid that we have picked up. See, the child is still coming follow up into OP. You can make him open the mouth and see a globular sort of thing at the posterior end of the tongue. Absence of tissue. This is mainly by diagnosing absence of tissue in the normal place. Lingual thyroid. double topic. I told you one more I have shown you a double ectopic thyroid. This is very important. You feel that uptake is very high, but there is elevated TSH and decreased FT4. The diagnosis that is made is dyshormonogenesis. I told you in the beginning various steps of the thyroxine, the thyroid hormone formation. One of the steps may be at fault. We have no means of doing the specific tests for perchlorate discharge tests and are not always available here, maybe in one of the researches. Again, another dyshormonogenesis. Now, we analyzed almost 62 infants with clinically diagnosed congenital hypothyroidism, and structural anomalies were seen in 18 of them. We had agenesis, ectopic was very high, lingual, sublingual, suprahyoid, and submental. Hormonal dysgenesis, 42. Increase iodine uptake in 33. Decrease in 5. Normal in 4. This is what I said. There may be, some involvement of the, antibodies that inhibits the release of hormone or the take of the interfering with the TSH action. Central hyperthyroidism, another one. Okay. The screening that is being practiced is TSH estimation. But most of the Western countries, advanced countries, they do a TSH with a backup with T4. I showed you the graph. What happened? TSH and FT4 are combined together. Or primary T4 backup with TSH method. So, because you should not miss, the whole idea is we should not miss a case of hypothyroidism. Because diagnosis is very simple, but meticulously it should be carried out. So a combined primary T4 TSH is an ideal method. A combination must be done during follow-up. Also, we should not be satisfied with estimating TSH alone. We should have T4. Okay. When I think this is also very important. I told you the fluctuations in the serum value. So every newborn should be screened before discharge. Optimally between 48 hours to 4 days of age, 2 to 4 days of age. Specimen collected in first 24 to 48 hours, false positivity elevation. This is what we have in that graph. False positivity is more in 20 to 48 hours. If discharge before 48 hours, obtain blood before discharge. This is very important when a busy hospital, fast discharge, collect a sample before discharge. And clinically ill or preterm neonate, blood can be collected up to 7 days. What is the treatment? Treatment with thyroxine of choice. 10 to 15 microgram per kilogram body. And the goal of therapy is to normalize T4 within two weeks. Concentrate on the T4 value. Normalize within 2 weeks. And TSH within subsequently, maybe 1 month or so. The pill should be crushed and suspended in few milliliters of breast milk. and then only it is administered early morning. Follow-up. It's very important. Just prescribing the Eltron and sending them home doesn't matter. But most important is a regular follow-up is essential. So you should monitor the serum level of T4 and TSH at 2 weeks and 4 weeks after initiation of treatment. Call the patient after 2 weeks, then repeat it. Again call the patient around 1 month. 2 samples are done at interval of 2 weeks post after initiating treatment. Then every month for 2 months up to 6 months of age. 1 to 2 months up to 6 months of age. Then 3 to 4 months from 6 months to 3 years. This is very, very important because the brain development, the growth, all these things are initially rapid during the development. So this is only to check whether the treatment is effective and the child is gaining weight and height as per the usual pattern. Then every 6 to 12 months until growth is completed. That means child is growing up to big age. Then 4 weeks after any dosage. Once you start a medication, do it 4 weeks. Ensure normal growth and development. That is important. What happens in normal thyroid tissue? I told you that ectopic thyroid, that thyroid tissue is normal. But you start treating that patient with L-toxin, that tissue gets atrophied. That means it becomes non-functional. That means this patient needs continuous treatment lifelong. Careful about this. Be aware. Then, how long you should treat? There are people who are 3 years. I will agree for transient hypothyroidism, this may be all right. But in a patient with dysharmonosis, agenesis of thyroid, ectopic thyroid, all such situations, the treatment should be lifelong. Now, I just want to mention one point. I happened to recently come across a baby in my family. The mother was hypothyroid earlier, on regular medication. She became pregnant. Her TSH level low. The person treating her did not bother about it. He went on giving her thyroxine. And when she was delivered, the baby had a stormy period, the first week of life. Jaundice, respiratory distress, and once it was estimated, the TSH level was too low and baby was hyperthyroid. So I told them the mother had this, they checked the mother and mother's TSH was too low, but she had such antibodies. So this TSH antibodies can enter the fetus and it can create neonatal issues, hyperthyroidism. Baby had a lot of problem, jaundice, which is said to be very rare, hepatomegaly, again very rare. This infant had tachycardia, but her rate was relatively higher. And treated by Amrita, by my own student of Deshri, she managed it beautifully well and she improved. And this is what when you test hyperthyroid status in the neonatal period, please don't forget to check the bilirubin value. Also, albumin, alkaline phosphatase, and of course, as I told you, and the blood count. So this is extremely important to pick up this condition. It is there. I have seen as a student, and also subsequently, those days the university facilities were practically nil. We had depend on our sixth sense, what should I say, and the clinical observation of the situations and the experience of the senior people. Remember, this condition is transient. 6 months to 1 year, they become all right, but it has to be picked up and needs to be treated. Thank you for the patient hearing. Ajay? Ajay Boya. Yes.
Thank you, sir, for that excellent talk, sir. So if anyone have any queries, you can type in the chat box or ask yourself.
How many of you have come across with hypothyroidism? Especially this is the situation where you can indicate growth hormone deficiency, primary hyperpituitarism. How many of you have come across? Anybody?
Question in the chat box. I will read it, sir. Is cord blood sample in for screening? Hello.
Okay, come. I can hear.
Sir, there's a question in the chat box. Is
Yes.
cord blood sample enough for screening?
Yes. See, the whole idea is we should have 100% coverage. You take a cord blood sample for, don't be happy with TSH alone. You do both TSH FT4. Collect it and assess the situation. Always time it with how many hours the child has crossed at the time of cord blood is enough. Then if there is elevated TSH, you should go for a repeat sampling. There's a schedule for that. At the end of first week, you repeat and then proceed further. The cutoff value taken is 20. In Indian situation, it is 20.
Okay, sir. Sir, there is another question. Suppose we start on levothyroxine without scintigraphy, then when will we next do the scintigraphy? Is there a stipulated time gap suggested?
This was a problem. I discussed with our nuclear medicine chief, Dr. Maharajan. He told me we can do it within 1 week or so, because as long as a TSH is elevated, you can do it. You can do it, you should do it. Tell a story. There was a girl coming from nearby place. She was about 9 years when she came to me. She had elevated TSH first, immediately after delivery. She was given Eltroxin for 3 months, stopped. After 3 months of stopping Eltroxin, again she developed features of hypothyroidism. TSH went about 100, more than 100. Again she was treated like this. Third time she came to me. I did scintigraphy. She showed hormonal disease. And then she started regular Eltroxin, and now she is doing very well. So as long as a TSH elevated remains elevated, you can certainly do it. Or temporarily discontinue for a few days, doesn't matter, but it is a must. You should know the full diagnosis before you treat a patient.
Sir, there is another question there. Some doctors treat with 50 microgram thyroxine for 4 days a week and then 37.5 microgram remaining 3 days of a week. Is this acceptable?
Now I told you, you should give it a 15 microgram per kilogram body weight, continue, and once the level of FT4 comes normal, you continue the same dose. Then you can change accordingly. I think a frequent monitoring of the level FT TSH is mandatory. Repeat every second week for a month, then every month subsequently for 6 months. So depending upon the level of FT4, you continue, and then upon the, take into account both the values for deciding the dosage. It should be given in the morning.
Okay, sir. So there are no more questions.
Okay.
So,
Sorry, because there was some problem with this laptop. I only got it corrected today
sir,
afternoon.
one more question is there. Suppose we miss
Ah.
blood, should we wait for 72 hours for next sample?
What for? Missing a tablet. Can you repeat it once again?
Suppose if we miss cord blood sampling, should we wait for 72 hours for the next sample? Like we
That
could not.
depends. Suppose the patient wants to. See, one is before discharge. Don't make it 3 days, 4 days. Before discharge. But if they can wait for 3 days, fine. But patient should not go without sampling. That's all. That's the principle. Then depending upon the value, you can follow it up. This is what is in medical college and Kottapuram hospitals. Early discharges happens. They do it as early as. But there is you should be prepared to interpret the value. The cord blood and the values only may be different. The surge I mentioned is to be kept in mind.
Okay, sir. For another question, if cord TSH is very high, above 100, can we start thyroxine directly before scintigraphy in poor resource setting?
You can start, but persuade it takes only 2,000 rupees. It is worth spending that money for the life of that child. Just 2,000 rupees. You give and send it for scintigraphy. No harm, because TSH is elevated. You'll be able to pick up the real costs, even if it is given for a few days.
Sir, another question, is there any role for immunoglobulin in severe transient congenital hypothyroidism due to maternal antibodies?
Maternal antibody role for, I have no idea. I not thought of it. Can anybody answer this question?
Okay, sir. And next question, is it necessary to start at 15 microgram per kg daily initially?
That is a recommendation. That is the standard recommendation. You may feel, I also felt that is very high, but once you concentrate on the FT value, it becomes absolutely right. To 15 micrograms, people say. It may be very high initially if you feel so. But give it, you repeat the TSH, FT4 and TSH after 2 weeks, you are not doing any harm in that way.
So can we conclude now, sir?
Okay. And thank you. Hope at least few
How
of
is
you are
there?
better. I'm sorry. trouble in transmitting because some problem. I am getting my laptop chain. It was not functioning 2 days back.
Oh, okay.
Okay. Ajay, nothing good. Neha?
Sir, Nihas is here.
Yes.
Am I audible? Sir, thank you for that nice session on thyroid hormones and congenital hypothyroidism. And your words are always heard with special interest by all the PGs and all others. Thank you, sir, for that nice session, and hope to have more sessions from you. Thank you, sir.
Okay. Okay. Thank you. Bye-bye.